Welcome to the Arbor Hospice and Palliative Care podcast, Support Throughout the Journey. I'm Margaret Adrian, Director of Innovation and Business Development for Arbor Hospice and Arbor Palliative Care in Ann Arbor, Michigan. In this podcast, Gloria Brooks, President and CEO of Arbor Hospice and Palliative Care, talks with Dr. Adam Marks about the unique facets of palliative care. Dr. Marks is Arbor Palliative Care Medical Director. He also serves as Associate Director of the Adult Palliative and Supportive Care Clinic at the East Ann Arbor Health and Geriatric Center. Dr. Marks is Assistant Professor, Internal Medicine at the University of Michigan Geriatrics. He has received both a medical degree and Master's of Public Health from the Wisconsin School of Medicine and Public Health in Madison, Wisconsin. Gloria Brooks.
So we're hearing a lot in the news today about palliative care. You can't turn on the radio or TV or look at a paper and not hear about it. So I'm wondering if you could talk about what is palliative care.
Great question, and something that a lot of people, even who are referred to my clinic, ask me. Well, gosh, why am I here? What is palliative care? What I often tell people is that palliative care is a subspecialty of medicine. It's made up not just of doctors, but of nurses, social workers, and chaplains, and others, whose job is to help people who have serious or life-threatening diseases to live as well as they can. Rather than putting the focus on the disease process, the palliative care team puts the focus back on the individual. And so what that means is we have several core jobs. The first is good symptom control. Patients who have a serious illness, be it cancer, heart failure, emphysema, or something else, often experience disabling symptoms that are interfering with the ability to live their life. The palliative care team pays exquisite attention to these symptoms. Rather than focusing on the disease, we focus on the whole person in front of us. And we ask them and their loved ones, what is it that's keeping you from living your life the way you want to live it? Is there an uncontrolled symptom related to your disease, such as pain, or nausea, or fatigue, or breathlessness? Is there anxiety around the illness or the changes that a person's body might be undergoing? Are there concerns for the future? What is the next year going to hold? What's the next 5 years going to hold? And how can I plan for that? So really recognizing that a serious illness doesn't just have physical components, but emotional, spiritual, cultural components that ought to be addressed in order to take care of the whole patient.
So people might wonder what would make them qualify to receive palliative care services. So I'm wondering, how would you answer that question for a family member who has a loved one who they think might benefit from palliative care?
This is another common question that I field a lot from patients and family members. Broadly speaking, anyone who has a serious illness who is struggling to maintain their quality of life qualifies for palliative care. It's probably important to recognize, however, that palliative care isn't just about symptom management. We also do a lot with what we call advanced care planning. Again, planning for that future a little bit. I'll give you an example. Early in my career, I took care of a lot of patients with Lou Gehrig's disease, or ALS. And this is a disease characterized by progressive weakness over time. It is a relentless disease without any cure. And many patients get to a point where they can no longer feed themselves. They need a feeding tube, or they have a difficult time breathing, and some people need ventilatory support. And so these patients are often faced with very difficult decisions. Do I want to continue more and more aggressive medical care to sustain me? Or do I want to avoid a life of dependency and instead focus on quality rather than quantity? These are the kinds of conversations that we can introduce to patients and families and walk them through. And so not only patients who are struggling to maintain quality of life, but patients or families who are faced with difficult medical decisions in the context of a serious illness can benefit from meeting with a palliative care subspecialist.
What kind of symptoms could be managed if they saw a palliative care specialist? What would be some symptoms that they would have that could be resolved with this sort of intervention?
Well, Gloria, Almost any symptom that a person experiences a serious illness, the palliative care team will have special expertise in. I'll tell you that myself and my colleagues have received particular training in things like pain control, particularly cancer-related pain, but also a variety of other pain syndromes, breathlessness associated with either heart failure or lung disease, confusion or agitation that sometimes people with dementia will experience, and it can be very distressing to loved ones. We can come up with both medication interventions and non-medication interventions to address nausea, low appetite, constipation, itching, hiccups, strangely enough, is a not uncommon symptom that we'll see. Really, almost any physical symptom that a person's experiencing becomes the focus of our attention to alleviate and to allow a person, again, to live as well as they can with their disease.
So, do people find there's a time limit that you can access palliative care services? Does insurance put a limit on that?
Another good question, and I think the reason that people think palliative care has a time limit, I think, is because people sometimes confuse palliative care with hospice care, which I'll discuss in a moment. But the short answer is no. There is no time limit to how long a person can receive palliative care. And likewise, there's no prognosis limit for a person to be able to receive palliative care. We see a number of patients who are hoping to have many years left of life in the context of their disease. Likewise, to see a palliative care doctor or a palliative care team, you don't have to give up other aggressive medical care. We see a number of patients who are actively getting chemotherapy or who are listed for an organ transplant or who are going back and forth to the hospital for surgeries or other interventions as dictated by the other physicians involved in their care. So to answer your question, there is no time limit to which a patient can receive palliative care. As long as a patient has needs that a palliative care team can address, they can continue to receive those services.
So, where would a patient receive the palliative care services? Where would they go to get these type of services?
Well, nationwide, most common place for a patient to see a palliative care provider, be it a physician or nurse practitioner or someone else, was in the hospital. So many larger hospitals will have palliative care consult services. So if you get admitted to the hospital and there's a need for symptom control or advanced care planning, you might meet with a palliative care provider during your hospital admission. It's really only been in the last 5 years or so that palliative care services have been developed for patients outside of the hospital. And there's two main places. One is a standalone clinic. So just like a person would go to see their cardiologist, or just like they would go to see their primary care doctor, a person can make a clinic in a palliative care office where they would meet with the physician and likely other members of the team, again, social worker, nurse practitioner, nurses, etc., to have their needs addressed. More recently, of course, in the last few years, there's been a growth of what we call home-based palliative care, which I often describe as a clinic that comes to you. And this is specifically designed for people who have a hard time traveling back and forth to clinics. And when we're talking about a service that is aimed for people who have a serious illness, it makes sense that a lot of people with this illness might have a hard time making the trip to a doctor's office, might have a hard time getting in and out of cars, walking across parking lots, going up and down stairs. And so these home-based palliative care services are designed to bring the care to where the patients are, and is just like the care a person would receive in their clinic. They receive a comprehensive symptom assessment as well as those advanced care planning conversations about how we can plan for the future.
So, as they access these services, Dr. Marks, what would a typical palliative care visit look like? It sounds like it's different than going to a well care visit, with a primary care physician. So, what would be included in that typical palliative health visit?
Well, Gloria, for the initial visit, it's often simply getting to know the patient, hearing the narrative, as I often say, of their disease. Because a lot of people that we meet have been living with an illness for some time, be it kidney failure, again, heart failure, or cancer. And so we try to elicit from the patient and their family the story of their illness. When did this start? How has it affected you from a physical standpoint, from a mental standpoint, from an emotional standpoint? Usually, too, in that first visit especially, we do a very careful and thorough review of systems, what we call a review of systems, where we're asking not only about pain, but going through the whole list. How are you sleeping at night? How is your mood? How is your appetite? Are you having any other physical symptoms that are causing you distress? And we take them point by point. What have you tried? What has worked? What hasn't worked? And how can we address this symptom in a way that's going to make sense for you? Recognizing that everyone is going to have different aspects of their symptoms that are going to need particular attention. So one person might say, I have bad pain, but I've had terrible luck with standard pain medications. Well, then great. What kind of alternative therapies can we think to bring to bear to this? Or the person who says, I've got terrible breathlessness, but I hate taking pills. Well, wonderful. What are some non-pharmacologic measures that we can take to address those symptoms? Two, we try to, at least at the initial visit, we try to explore some of these bigger picture issues. So we'll ask someone, when you think about your care going forward, what's important to you? What are you hoping for? But then also the flip side of that is what are you afraid of? A lot of patients I meet will say, well, gosh, I know that over time, I'm going to get worse. I really hope to stay at home as long as I can, or to stay as functional as I can. One of the things I'm worried about is maybe being a burden on my loved one, or I'm worried about having uncontrolled pain. And so we can talk a little bit about how we can plan for these things. What are we going to do if your pain gets worse? What are our next steps going to be? What if home no longer is a safe place for a person to be? How can we either bring more support into a home, or if that's not possible, how can we plan for a safe transition of care to a location where a person can be better cared for? That's typically what a person can expect from a palliative care assessment. Again, just the narrative, getting to know a patient, the physical assessment for symptoms, and then also some of that larger advanced care planning.
So you've been a palliative care physician for some time now, and what do you find are some of the challenges in working with people with serious illness?
Probably the biggest challenges that I have and that my patients and their families have is simply navigating the health system. A lot of family members I meet who have complex or serious illness simply are overwhelmed with certain aspects of care. One of the things I often hear is, I don't just have one doctor, I have 10 doctors. And trying to figure out who I contact for what is just a headache. Who do I contact if I need a wheelchair? Who do I contact if I need physical therapy? Who do I contact if I need a refill of prescriptions? And how can I understand my care such that I remain in control of it? If a doctor says, well, gosh, we need to do X, Y, Z, wait, do I really need to do that? How do you know I need to do that? What if I don't? And so one of my big roles in these situations is trying to help with effective and clear communication to patients and families, not only about their disease, but about the treatment options for them. And so again, I keep on using this example of the ALS patient, but a patient might have been told by their doctor, well, you're having a hard time eating and drinking to maintain your weight, so we need to put in a feeding tube. And so time out, let's talk about what that means. And let's talk about how is this going to help you, but then what are the downsides of it? These are the kind of things that I walk through with patients, and that I think that can sometimes be the most challenging, is figuring out a way forward in a way that makes sense to the patient. Because very clearly, different patients met with the same disease will have different, what we call goals of care. And so one patient might say, I want the most aggressive care possible to sustain my physical existence as long as the doctors can. And then I say, great, well then I make these recommendations, I think you ought to pursue these things. Another patient, again, faced with that same disease might say, listen, I don't want to be hooked up to machines, I don't want artificial life support. If it's my time, it's my time. And I want to do that in as comfortable and natural a way as possible. Great. If that's your goal, then let's talk about these things in the context of that goal. And how will some of these proposed interventions, whatever they may be, how are they going to get you farther or closer to that goal? It's really that navigation part that I frankly find the most challenging.
And so, like most relationships, I think with physician and patient, that communication is key. And it sounds like part of that communication and understanding, it's really an education question, I'm sure comes up between you and your patients is how does palliative care differ from hospice? Because the two sometimes, as you've referenced earlier, can be commingled. Some people don't understand the difference. So I'm wondering if you could explain that to us today.
Absolutely. I often describe palliative care as being a very broad umbrella and hospice care as being a small part of that umbrella. I think the confusion is that palliative care and hospice care share the same goals. That is, a focus on a person's quality of life. The difference is this: hospice is a very narrowly defined Medicare, Medicaid benefit for people who we think have less than 6 months to live. It is a home-based plan of care, and that includes home nursing care, health aides, home social workers, physicians, medical equipment, those sorts of things, to allow a patient to stay where they want to be and to allow a natural death to occur. So this is for patients who have said, I don't want aggressive care. I understand that my case is terminal, and when my time comes, I want to focus on comfort. Palliative care, in contrast, there's no, as we discussed earlier, says nothing about a person's prognosis. A person can meet with a palliative care doctor and enroll in a palliative care program who have hopefully as many years left of life. A person can receive palliative care while continuing to receive aggressive medical interventions. And enrolling in palliative care does not mean that you're foregoing hospital-based care. Sometimes people think that if I'm meeting with a palliative care doctor, it's because I'm dying. Or if I meet with a palliative care doctor or a palliative care team, it's because my other doctors are giving up on me. And it's absolutely not the case. Palliative care is about helping people live as well as they can for as long as they can. And that's a point that maybe people miss. Because sometimes palliative care, people are under the assumption that palliative care means sacrificing quantity for quality of life. And we're getting data now that shows, no surprise, people who feel better live longer. And so I often tell people, I'm not about helping you live a short, happy life. I'm about helping you live a long, happy life. Because in reality, this is what everyone wants. Very few people say, first of all, no one says, I'd like to live a long, painful life. But very few people say, I'd like to live a short, happy life. They say, I'd like both, please. I'd like to live a long, happy, and comfortable life. And that's the goal of palliative care. Our focus is on helping a person live as well as they can. And that, I think, is the main difference between an effective palliative care program and that hospice plan of care.
Having that relationship, being able to establish it well, and helping educate your patients on the different types of care can help as the patient's disease is progressing. So how do you help them decide what is the best course of action?
Well, very simply, we always go back to what a person's goals are. And so I never meet with a patient with the intention of talking them into or out of the therapy. So I never meet with somebody and say, oh gosh, you shouldn't do chemotherapy, or gosh, you shouldn't get that next surgery, or gosh, you shouldn't get a feeding tube. I always go back to that. What are you hoping for? And what are you afraid of? And so a person who says, I am really afraid of living a life of dependency. I am really worried about not being able to take care of myself and needing to go into, a nursing facility. I might say, well then, gosh, is this next aggressive surgery really going to help you then? Or does this only, carry substantial risk of debility? Or a patient who says, I really, when my time comes, I want to face my end of life in comfort and dignity. Then I might say, well, gosh, with that in mind, maybe we should talk about your code status. Does it make sense to be something that we call full code, where you get chest compressions and shocks and intubation? Or does it make sense to change your code status to what we call do not resuscitate, where if you get so sick that your heart stops beating or you can't breathe on your own, we allow a natural death to occur, rather than to continue to provide aggressive medical interventions? It always comes back to the person's goals of care. And what I say in these situations, there's no right answer or wrong answer. There's only the answer that makes sense to you. And that's why we have these conversations, to try to navigate those waters together.
It's a conversation, and I think that's an important concept for people to understand. It isn't a one-time or a one-sided interaction with somebody, and that's why that relationship between the physician and the patient is so important. And that relationship that we have as family members with our loved ones. So if I know somebody who could benefit from palliative care, what is the first step that I should take to try and help them get the services that they need?
Well, I think there'd be a couple of different options. Arbor Hospice has our own home-based palliative care program, Arbor Palliative Care, which can be accessed in a couple different ways. We have our general number. It's area code 734-794-5678. We accept referrals not only from physicians, but from patients and families as well, and can set up a time to meet if a person meets the criteria for our program. But probably a good starting place would be to ask your primary doctor, be it your family physician, or again, if a person has a subspecialist that's carefully managing their care, such as a cardiologist or an oncologist, asking them about palliative care services in their area that they might be eligible for. There's also a website called getpalliativecare.org. No spaces, no underscoring, just that getpalliativecare.org, that can help people identify palliative care resources in their area.
Dr. Marks, what are some of the unique aspects of Arbor Palliative Care's program as compared to other services that you have seen offered in the community?
So there's a couple of things that I think makes Arbor Palliative Care stand out from some of the others. First, as I mentioned before, a home-based program. So for patients who have difficulty leaving the house, these are services that can come to you. And I think that alone is a big advantage compared to other either hospital-based or clinic-based services. Another main difference is that we're a standalone agency. You don't have to be receiving other home care services to get Arbor Palliative Care. We bill through Medicare Part B and bill directly. So your loved one doesn't need to be getting home nursing services or other home-based care in order to access Arbor Palliative Care. Finally, we are a physician and nurse practitioner-based service. We have experience with people with a wide variety of conditions, again, from advanced dementias to heart failure to cancer. And I think we have the expertise that our patients are looking for in managing not only the symptoms, but again, in navigating the way forward with complex illness.
I'd like to take this opportunity to thank our listening audience. If you would like further information about Arbor Palliative Care, please contact me, Margaret Adrian, at madrain, MADRAIN, at arborhospice.org.